Good afternoon, everyone. Thank you for joining our webinar today. We're excited to have you here as we discuss an important topic in PA education. A brief introduction before we dive in. My name is Alyssa Naglieri. I'm a PA, and I've had the pleasure of working both clinically and in higher education as a faculty member. Currently, I serve as a simulation instructor at Monmouth University in New Jersey, where I run live simulations for healthcare students and residents. I also work here at Sketchy as a PA consultant, helping to enhance the learning resources for PA students. So I'm very happy to be hosting this webinar. Today, we'll be discussing the effectiveness of virtual simulation in enhancing clinical reasoning in PA education. As PA educators, we recognize the challenges of developing strong clinical reasoning skills in a controlled learning environment. And virtual simulation offers an innovative approach to bridging the gap between didactic knowledge and clinical application. So by the end of this session, the goal is that you'll have a better understanding of how virtual simulations, specifically our platform DDX by Sketchy, contributes to PA education, along with the proven results on the effectiveness of DDX at the University of Wisconsin's PA program, and then practical ways to integrate it into the curriculum. So throughout the webinar, we encourage you to participate by asking questions, by using the chat function, and we'll also have time for Q&A at the end. So let's dive in. At this time, I'd love to introduce our guest speaker, Kevin Wine. He's the Assistant Program Director of the University of Wisconsin, Madison's PA program. His PA program piloted DDX, and he's here with us today to be able to review the results of the pilots, as well as discuss practical ways to integrate DDX into the curriculum. So thanks for joining our webinar today, Kevin. At this time, please feel free to share a little bit about your role in PA education and your clinical background.
Sounds great. Thanks so much, Alyssa. Yeah, my name is Kevin Wine. I've been a PA working primarily in emergency medicine since 2005, so entering, I guess, my 20th year. I've also been a faculty member here at the University of Wisconsin-Madison since 2012, and then I've had various roles. But one of the things that I've been doing consistently since I arrived is directing our emergency medicine course, and had really tried to, over the years, it's the course that we take in the spring before our clinical rotations start, and students always have a lot of trepidation about their emergency medicine rotation in particular. And so throughout the years, I've been sort of trying to build in ways to sort of simulate that environment through cases and whatnot, primarily in class. And this is just an opportunity to really learn about a really amazing program that really uses AI to really enhance those opportunities. And I think what we'll find with the pilot is that our students have had a really positive response to it. So glad to be here.
Awesome. Thank you so much, Kevin. Now that we've introduced today's topic and Kevin, our guest speaker, let's take a moment to consider why virtual simulation is becoming such an essential tool in PA education. As educators, we know that developing strong clinical reasoning skills is not always straightforward, unfortunately. Despite our best efforts, there are persistent challenges that can impact student learning and preparedness for clinical practice. So let's take a closer look at each of these areas and how they may affect PA education. So one of the biggest challenges in PA education is ensuring that students are adequately prepared before they enter clinical rotations. So I found this as a personal challenge myself as a PA educator. With most programs reserving a year for didactic instruction, it's challenging to be able to fit in the required curriculum in such a fast-paced, high-pressure environment, while also preparing the students for that next level of critical thinking that's involved in a patient encounter. So traditional methods like lectures and case discussions provide that foundational knowledge, but unfortunately, sometimes they don't always translate into that real-time clinical decision-making skill process. Another challenge is providing students with diverse and consistent clinical experiences. We know that there's a markedly increasing issue of clinical site shortages with competition between multiple healthcare specialties, leading to a lack of diversity of cases. Students are also limited on the types of patients they encounter, which can vary widely depending on the location of the program, preceptor availability, and the volume of the amount of patients. Remediation continues to be a relevant topic for programs. When a student is struggling specifically with clinical reasoning, it's not always easy to pinpoint exactly where the student is going wrong. To add to this, there still seems to be unanswered questions regarding the most effective remediation strategies and the appropriate balance of resources that's provided. Adding on to this list, keeping students engaged in learning is another challenge, especially with our didactic students being in a classroom Monday through Friday, 8 to 5, and even for our clinical students who might be preparing for end of rotation exams, but those passive learning methods can sometimes feel ineffective. And then finally, assessing clinical reasoning objectively can be difficult. Traditional exams are going to test knowledge, but they don't always assess how well the student can apply that knowledge to clinical scenarios. So these challenges really highlight the need for innovative educational tools that can enhance clinical reasoning development. And this is where virtual simulation platforms like DDX come into play. So let's go ahead and chat with Kevin about his experience with DDX at his program. So for context, Kevin and I initially met at PAEA this past year, 2024, where he attended our DDX presentation. So Kevin, I'd love it if you could share a little bit about what led you to explore virtual simulation as a solution for your program and what prompted you to attend the presentation at PAEA.
Thanks, Alyssa. It was a couple of things actually. So as I mentioned, over the years, I've been really trying to think through a lot of like, how do we actually prepare students well for rotations? How do we make sure that they have a comfort level with what they're likely to see and kind of, how to approach a patient. The other part is, working in emergency medicine, it's very kind of hit and miss, much more hit in recent years. But, what you see ends up really depending a lot on what shows up, what walks through the door, right? It isn't like you have a clinic appointment or even know what one day is going to look like from one day to the next. And so to have some sort of consistency for students to be like, okay, this is how you want to work up your chest pain patients. This is how you're going to work up an abdominal pain, et cetera. Or even to give some students some practice with that is something I've been thinking about for a long time. And so this just seemed like a great opportunity to use simulation. I've also kind of intrigued, admittedly somewhat terrified of AI and wanted to learn more about how it's being implemented. So that's part of it. The other big part of it is our program is currently going through our accreditation process. We just submitted our application last week. So if I'm looking quite tired and bitter at the world, that's what that's coming from. But really, what we've been thinking a lot about is assessment and how do we actually prove that the program and the protocols and all of the resources that we have in place are actually doing what they're supposed to do. And that assessment piece is something that I've been really mulling over a lot. And thinking about like remediation or students who have attrited for various reasons, how do we actually say this is what we've done to do remediations, or this is what we tried to do to get at specific skills, not just saying, well, you failed your emergency medicine rotation, we're going to have you do another one, or you really want you to work on your ability to come up with a differential, and we share that with the preceptor and they can kind of highlight that. But it would be great to actually measure how well a student is actually doing in that and have a much more objective measure rather than kind of the perceptions of a preceptor on a given day. And so just it was all those sort of things. And then the last thing was actually the name, the DDX. One of the things I think a lot of people would agree with is students really struggle with coming up with a differential. The way our program is set up, we'll do 3 weeks of cardiology, 2 weeks of pulmonology, 3 weeks of GI. It's very much segmented, and so students get pretty used to thinking about what diagnostics can be used. They'll think about the pharmacology and even just like the pathophysiology and whatnot. But then when it comes to applying that to a situation where a patient doesn't necessarily fit in a box to say like, oh, well, we're in the midst of cardiology, so whatever comes through the door is going to be related to the heart. To say like chest pain can be coming from several different areas of the body, or several different systems could be involved in that. And how do you decipher that or build a differential and stratify it was just a skill set I think our students have really struggled with. They eventually figure it out, But if there was a way, I think, to get them better prepared for that, I think that they would have even that much more of a positive clinical experience, and we'd be able to actually, as I was mentioning, assess it much better. So those were kind of the things that kind of led me to strike up the conversation with the listener colleagues.
Awesome. Thank you so much for your insight on that. Do you mind to describe or provide a brief overview as to how the pilot was conducted for both your didactic and clinical students? I know
Mhm.
you had started with your clinical students first, and then you piloted with your didactic students soon thereafter. But do you mind explaining how you went about doing it?
Absolutely. What I had done first was just actually ask a listener colleagues to say, is it possible for me to take a look at the library and just to sort of see which cases, because there's a library of cases, which ones may fit best with where our students are at. And to be honest, I didn't know a tool like this, would it be best utilized in the didactic year, best utilized in the clinical year, some combination of both. And so what we did is we had an EOR coming up at the end of last year. And essentially, I just said, okay, asked my colleagues to devote an hour, and they were willing to give me that. I brought bagels in. We came up with a case. The folks at DDX were wonderful in terms of I just supplied some email addresses. There was a couple steps just to get them access. And basically, what we did is over the course of about 40 minutes, the students did a pre-survey. So they actually did some baseline data in terms of like what they're thinking about in terms of their ability to do clinical reasoning or diagnostics or build a differential, et cetera. Melissa will be sharing about that shortly. We did the pre-survey. They spent some time going through the activity itself, and that was probably about 25 minutes or so where they're actually running through the simulation. We left it very open-ended. We didn't grade it or anything. We kind of said, hey, if you want to, talk to your buddy next door about, whether or not you're getting all the stars on the thing, that's totally fine. Kept it very loose. And then at the end, we did a post survey. And then I just asked them to kind of just share with me their experience. And that was really where it kind of came through. You have where we hadn't known anything about the data yet, but the responses from the students was kind of overwhelming. They loved it. They felt they were not bitter at all at showing up at 7:45 on a random Friday. It made for a longer day, but they were like, this is really time well spent. They really enjoyed it. They were excited about the fact that a tool like this could be incorporated, and they really saw a lot of immediate benefit and benefit compared to what we're currently using. We use a fair amount of aquifer cases and other types of software that's out there, and the students just felt like this was really a fun way to practice some skills, and they really just enjoyed the whole session. So we did that with the Clin year, got some data, and then our current didactic students had just finished their cardiology module, and as it was, the case was related to chest pain, and so I wanted to use the same exact case. So about 3 weeks later, we ran through it with our didactic students just to see kind of where, we did the same pre-survey, the same activity, the same post-survey, just to see how the two groups sort of compared. And we're going to run through that data here shortly. And then basically the folks at DDX were able to kind of take the responses, come up with some great summary slides that we're going to be using within our program, where basically I'm going to try to make the pitch to our faculty to say this is something we should look at purchasing because I think it would be very useful. So that's kind of how that was set up.
Awesome. Thanks for that, Kevin. And I just also wanted to mention that Kevin wanted his faculty members to also pilot the cases as well, so they can see from the faculty side how DDX can potentially be implemented into the curriculum. So we'll go over that towards the end of the webinar. For the audience, as I walk through the results of the pilots, I'm also going to be providing a live demonstration of the case that the students piloted. So it's our chest pain case. So you get a little bit of insight into how the simulation is structured and how to navigate through the case. By doing this, you'll get a clearer picture of both the student experience and the key findings from the pilot as well. So let's go ahead and get started with that. So you could see over here on the left side of the screen, we have our chest pain case up. And this is exactly how the students encountered the case. And over to the right-hand side here, we have, we're looking at the confidence changes pre and post pilot upon using DDX. And it's broken down into each skill involved in a clinical encounter. Feel free to use your Zoom function in your account to be able to enhance the sizing of the stats, because depending on how your account's set up, you might need to enhance the sizing a little bit. So let's go ahead and start with the left side of the case here. all of the cases in the DDX library present the student with a one-liner chief concern along with a set of vitals. So here we have a 52-year-old male presenting with chest pain. So let's go ahead and start the conversation. The student is then going to be instructed to obtain a history. So let's actually start the conversation with the patient so we can see the interaction within the platform. Here we have the patient saying, hey there, I've been having some chest pain recently. So I'm going to play the part of the patient and I'm going to respond. I'm sorry to hear that. When did it start? Patient answers, it started about a week ago. Let's ask some more questions. Is it constant? And what I'm trying to do here is elicit the key findings. So you can see in this top right section over here, we're going to have stars that we want the students to obtain. These key findings are going to be triggered by pertinent positives and negatives as determined by our subject matter experts who have written the case. Let's write another question. Does it radiate? Okay, perfect. So you get the idea here. Students almost use this as a game to see if they can obtain all of the key findings. And I'm going to transition to the right side of the screen here. We have the results for obtaining a history. We have both the didactic and the clinical students that had a positive percent change before and after the DDX case. But I'd like to ask Kevin for his insight on this. Kevin, do you have any ideas as to why the percent change in confidence for obtaining history was greater for the didactic students versus the clinical students?
Sure. I mean, I think it's probably just practice, right? I think that with our didactic students, they're so used to being in the classroom. They very seldomly, I mean, we do some simulated patients. We bring our students over to our university hospital where they do an H&P, so they get very limited direct patient interaction. And so I think because of that, they just don't have a lot of like confidence in their ability to elicit a history, or am I going to ask the right questions, or even just talking to people. I think sometimes they're so immersed in the book learning, I think they kind of lose some of their social skills or trust that they're able to actually have a conversation with a stranger and be able to do this. And then obviously as they get into it clinically, they realize that yes, they can certainly do this. But it was great to see a positive development even for our clinical year students, to say that this scenario kind of helped them think it through in terms of asking questions. And then to Alyssa's point about, trying to get the stars, they're such type A folks. I mean, I was like, you can't advance through the scenario without getting all the stars. Just ask you like, yeah, there's more information. Do you want to keep going? And our students were just so fixated on, like who got the more and that sort of thing. So they had a lot of fun with it. But it was great to see that actually they felt like it did actually help their confidence a bit.
That's awesome. Great to hear. And thank you for your insight on that. Yeah, it looks like the clinical students have a baseline confidence level that's much higher for history. And correct me if I'm wrong, Kevin, but these clinical students are graduating in May, right? So
That's
they're
correct.
feeling pretty confident in their history taking skills, which is a good thing.
Yeah, they've just
Um,
finished EOR. This was EOR 3. So they're, just more than halfway through. They have 2 rotations left. So for us.
awesome. And going along with this, do you mind sharing your thoughts on early exposure to history taking? Do you think this particular portion of the DDX case is appropriate for the beginning of didactic year, where students are just learning their foundational courses?
I do, and what I really kind of like about it is that it seems like DDX is actually really trying to think through different levels of cases where some may be much more appropriate for a clinical year student where you need to, solicit the physical exam, solicit lab results, et cetera, and actually ask specific questions. In other cases, they're kind of given to you. And so you can actually kind of almost find a case that fits with where your students are at certain points. But that history taking component is just something where I feel like the more practice they can get, the better. And it helps them think it through, I think even on like exam questions where they're starting to think about, okay, what are the pertinent things I should be asking? And if there's a piece of data there that isn't there, Is there a reason that's not included? So I feel like it's got a lot of really cool potential applications for students even much earlier in their learning process.
Great. I completely agree. So let's go ahead and head to the physical exam section over here on the left-hand side. So for this particular case, the physical exam is provided for the student because it's unremarkable. However, in other cases, the student might need to go through the physical exam step by step, asking for specific findings, and then key details are going to be revealed based on what they ask for. So if we head to the results section over on the right-hand side for physical exam, we could see a consistent change in perceived confidence levels for both didactic and clinical students. Again, the base confidence levels for clinical students is higher. And I just wanted to mention that the goal of the physical exam section in DDX is to help students align their confidence level with their skill level. Kevin, in your experience, are there any common areas where students lack confidence in physical exams, whether it's in identifying abnormal findings or creating a systematic approach to exams? I'd love to hear your thoughts on this.
I think it's both actually. And so I think students definitely struggle with their confidence in terms of, am I going to pick up that murmur? Am I going to, hear diminished lung sounds or what have you? My neuro exam, they they still can't see the fundus of the eye. I mean, there's all sorts of things that just come with practice. At the same time, I do think there's a lot of utility in even just remembering to say like, okay, chest pain, what are the relevant parts of this? And being challenged to say, okay, I haven't done this component of the exam to know that they actually need to do that step. I think is the other part of that they need to develop some confidence in, because they kind of approach saying like, am I going to remember everything? And so something like this I think just gives that practice and hopefully that confidence that, yeah, they will remember those key parts when they find themselves in that situation.
Absolutely. Next, we're going to head into the differential section. So now we're greeted by Dr. Reed, who's the supervising attending for this case. You can think of her as a facilitator or teacher. Throughout the case, she'll guide the student and ask key questions to reinforce their learning. And at this point, the student is asked to develop their first differential diagnosis. So let's go with something reasonable for the sake of this. Able? And if there's spelling errors, normally the system picks up on it. So no worries there. So at this point now, Dr. Reed is going to ask for my rationale as to why I chose stable angina as one of my differentials. So let's say chest pain, left arm, exertion. Perfect. And she gives a rationale as to why that was probably a good differential. But now let's give a differential that's probably unlikely. Laxus. And I definitely spelled that wrong, but that's okay. The system will pick up on it. So the attending explains that anaphylaxis is probably not a great differential on this list, but I really think it's anaphylaxis. So I'm going to challenge her. I'm going to ask her why it's unlikely. So as you can see in this section of the case, the student's getting real-time feedback from the instructor. These cases were really designed to feel like you have a live facilitator in class while running through the cases. So you can see her response here. Let's run through the results for the differential section over on the right-hand side of the screen. Similar to the perceived confidence changes for the physical exam, developing a differential has consistent positive changes for both the didactic and the clinical students. Again, those base confidence levels are going to be higher for the clinical students. Kevin, in your experience with using the platform, do you find that this framework provides a less intimidating environment for students to practice their differentials?
That seems to be the thing. I mean, of all the aspects to the program that I really find valuable, and there's a number of them, our students really struggle with putting together a differential. Like it's one of the skills that we really try to hammer home. It becomes easier as the clinical year goes on, but it is something that students A don't know how to think about necessarily as clearly as we'd like, or B they might feel kind of silly about throwing something out there and they're not sure. And so the ability to practice with something that's not, objectively judging them. I mean, who knows? Maybe somewhere in the ether it is, but it is. I think students really found it valuable to be able to throw something out there and then actually provide a rationale for it, right? They can't just say, "Oh, I think it's this," without having a reason why, right? And I think even on rotation, some of our preceptors don't necessarily take the time, whether because of a busy ED or whatnot, to really challenge students to get at their thought process. Like they give us the right answer and then we're on to the next thing. And so this to really actually ask them to drill down to say, okay, why do you think that? For both incorrect or correct answers, I think is really valuable and helps the students to really hone their ideas quite a bit in terms of their thought process and how to approach a case like this.
Absolutely, I agree. I think the process of them having to justify their differential is really valuable in this case. It gives you a lot of good exposure.
Mhm.
Wonderful. So we're going to head to the order section. In this case, the attending already put through the initial orders, but sometimes the student is going to be responsible for that. It really all depends on the case. So now we're at the results interpretation section, and this gives a good example of the interpretation of the results. Here we can put anything for the patient or for the student to work on and read. For example, chest x-rays, limb x-rays. Obviously, we have an EKG here. So let's blow this up. We'll take a quick look at this, and I'm going to respond. Normal rate, regular rhythm. No ST segment changes. Wonderful. We're going to continue to the next step. Now we are greeted by Nurse Clark, who explains that Mr. Jones is having chest pain again, and he wants to know if we can go in and take a look. So the EKG monitor is still hooked up. Let's take a look at his new EKG. And oh man, I don't know about you, Kevin, but that's not looking good to me. So ST segment elevations in V2 to V4. Okay, now we're going to head to the management section. But before we do that, I want to head to the stats for the ordering and interpreting of diagnostic tests. So the results demonstrate a significant change in perceived confidence in the student's ability to order and interpret diagnostic tests after using the DDX tool. Specifically, a 24% increase in the didactic student confidence with ordering of tests, and a 29 and 26% increase in perceived confidence with interpreting diagnostic tests. So it's looking like as we get deeper and deeper into the case, the perceived confidence percentage continues to rise for students. Kevin, have you found in your experience as a PA educator that ordering and interpreting diagnostic tests is something that students continuously struggle with?
It is as much as we try to reinforce it, with our book knowledge in the didactic year, students do struggle on clinical rotations or in actual situations to be like, okay, I could order anything. What do I actually want to order in these cases? And it gets more so even, when the differential is that much more broader, might involve different body systems, that sort of thing. And like other parts, this case gave you the tests that were ordered, but other ones could give you feedback, right? In terms of saying, well, that isn't really, I want to get a rectal exam. Maybe that's not appropriate for a chest pain patient, right? So it would actually give you feedback about that too, because I think that is an area where students struggle. What I find a lot when I'm precepting students on rotations is to say like, okay, what do you want to order? And because we're in the ED, it almost gets this cookbook feel like, oh, well, everyone gets a CBC and a BMP and a troponin or whatnot. But to actually think through like, okay, what are we looking for on this? Like, what do you actually like? What do you want to get out of your CBC? To challenge them a little bit to think that through. And then the interpretation part is that much more complex, right? When real time where they're actually think, okay, I got to delve back, dig out my EKG knowledge and actually like work to interpret this, and just to kind of give them some confidence to say, oh yeah, yeah, here's your EKG. What are your steps? What did you learn in terms of your approach to kind of how you go through this? And that gives you feedback about that, which I think students really find valuable. So when they actually get to a real patient, they've had that simulation a bunch, and then hopefully it's a little less scary, right? They can actually tune out the environment a little bit and think through like, I actually know what I'm supposed to do in this situation because I've been through it a bunch. And that takes away that kind of fear aspect, I think, quite a bit.
Absolutely. And I know we were talking the other day about this with the ordering of diagnostic tests when students are initially learning. You're talking about a CBC, a CMP for one particular case. Then you switch to another case, and this patient's coming in with dysuria, and they're still ordering a CBC and a CMP. And we're like, wait a second, this patient is coming in with, pain with urination. That might not be necessary. So sometimes being able to provide that rationale as to why they want that diagnostic test ordered is super important. So I completely agree with you.
Yeah, and
Um,
those cases where certain tests are not needed, right? That's the other part too. Is like
right.
sometimes students are like they're so tentative they want to get every single possible data piece and forget to go back to the history and be like, you know what, the odds of this person having severe anemia or whatnot, might be very low, and so maybe I can rule this out just based on what I've been given in the history. I don't necessarily need to do a test for it, and that's a skill that I think our students really struggle with, and it comes with time. And obviously, hopefully, when they get into clinical practice, the more experience, the better. But it'd be great to, again, help them develop these skills and this feedback really early on to really mold them into clinicians who are thoughtful about how they approach testing.
Absolutely. And then we're going to head into the last section of the case. So the management section. So at this point, it looks like we're dealing with the STEMI. The nurse wants to know what we should do at this point. So let's start off by calling the cath lab. Let's get IV access. Aspirin orally. So hopefully at this point you get the gist as to the management. The nurse is going to keep asking you what you would like to add to the management regimen. Over here on the right hand side, we see huge perceived confidence changes again with the management plan for both the didactic and the clinical students. So hopefully the students feel like their ability to manage patients more effectively uh, has improved with using the DDX tool. So Kevin, with this in mind, do you feel that with the use of DDX, students will be more prepared to explain or even defend their management decisions during clinical discussions?
I certainly hope so. And one of the things that I love about this is it kind of encourages patients to sort of, or sorry, students to own the patient, right? So this is the idea on
Right.
rotation where, yeah, they're there and they're kind of involved, and they might get asked like, oh, what would you like to do in this situation? But they're not necessarily the one, putting in orders or doing whatnot. This really encourages them to say like, okay, this is what should happen right now. And I think the more you can, again, maybe not first rotation, but over time, you really want them at the end of their clinical experiences to be able to kind of own a patient and say like, yeah, I am the one responsible. This is what I would like to do, and have that confidence to know where to approach things. And again, I love the fact that it gives you feedback in terms of, okay, you forgot this aspect, and then hopefully the next time through you'll remember it. But again, the more we can, I think, encourage students to really kind of really take that ownership, it's an important skill set that gets fostered over the course of that clinical year. And again, it's one of those things where working in emergency medicine, it'd be great if one of these came through your door on every single shift and you got a chance to practice. But not every student is going to get put in that situation, depending on where their clinical experience is taking place or the type of setting, whether, university versus community hospital, et cetera, et cetera. So this is a way to kind of say, okay, yeah, you're in this situation. How are you going to manage it in this situation? And challenge them it really puts them in the shoes of somebody who might be in that spot.
Right. I agree. Um, I also just wanted to run through this slide before we head on to the faculty insights section. So in the post-pilot survey, the students were asked to compare DDX to other case-based learning tools. So we really see a huge positive change here, indicating that there's a strong preference for DDX over other learning tools, which is fantastic. That's what we wanted to see. I'm going to, for the sake of completing the case, I'm going to head to our multiple choice questions. So every case ends with at least 4 multiple choice questions, and it'll give you a rationale as to why the answers are correct or incorrect. So I'm just going to scroll through this quickly just for the sake of time. Once we get through the questions, we are going to be able to review a course of care or a patient care outcome summary, as well as key learning points to take away from the case. When we finally get to the end of the case here, we are able to see, or the student is able to see, all the key findings that they've obtained and ones that they may have missed along the way. So they can scroll through the different sections here to be able to see that. Now, from a faculty point of view, faculty members can assign these cases to their students. So that's what Kevin did. He was able to assign the chest pain case to his clinical and didactic students. And there's also an insights tab that we can review at the top here. And these are all fake students, but we can see the average time it took the students to complete that particular case. So if there's a case that took a significantly longer amount of time for a student, maybe they struggled in one of those sections. Maybe the case was more complex. So you can kind of get an idea as to the student's progress here. And as we take a deeper dive, we can head into the exact case and see how the students did in each particular section of that case. So we can go ahead and review how they did on history, how they did on physical, how they did on differential, workup, management, etc., to really get a great overview of their performance on that case. So I just wanted to mention that before we head into the faculty insights section here. And now let's see what the faculty members had to say. Just for context, the faculty members piloted 2 cases. They piloted the chest pain case, the one that we just went over, and they also piloted the ovarian torsion case. We have a small sample pool, but it'll at least provide some insight into the faculty's view of DDX. The results that we have here are comparing the effectiveness of DDX to online scenarios that the university is currently using. So the results are going to show a 27% positive change here, indicating that faculty members found that the DDX tool is significantly more effective in helping students develop a differential diagnosis as compared to the current online scenarios that University of Wisconsin is using. Same with ordering, interpreting, diagnostic tests, and overall clinical reasoning. We see huge positive changes when comparing DDX to the current online scenarios that the program is using. So Kevin, I would love to get your feedback on this. Do you believe that the faculty insights, what I just showed you in the platform, do you think that would be useful for remediation purposes in your program?
I do. One of the things that we actually just had a conversation about this morning in our faculty meeting was talking about remediation outcomes for students who are struggling, right? And to try to say, how do we actually provide some useful feedback in a way that they can really practice the specific skills that we want them to learn. And so what I liked a lot about DDX was the fact to say, like, again, differential might be an area where people are struggling, or interpreting tests. We can certainly talk to them and we can refer them to resources. I mentioned Aquifer, that's cases that we're currently using, and I certainly don't mean to hate on what the products that they're putting out or whatnot, but this really provided a really kind of a fun, our faculty enjoyed it as well, but we're in terms of having a good time going through it. But what they really found useful was to say, like, oh, we had a student who is struggling with this. It would be great to be able to say, in addition to, some feedback, maybe specifically to the preceptor, to say, I want you to kind of help hone these skills in this particular student, to be able to give the student some practice so that they can see their own progression. And it's not just based on, again, who shows up in the ED and then they're presenting a case and they're getting that feedback, but to actually be able to have some measurable outcomes to say, look, you ran through these cases. This is where you struggled. Let's have you do, we can target our approach so much better to be able to say we want them to learn these specific skills. And that just seemed, I think, something very appealing to the faculty in these areas.
Great. Thank you for your insight on this. Um, as we're nearing the end of our webinar, I'd just like to discuss some practical ways to integrate DDX into various stages of the PA program. To note, right now we have 27 cases. All of the topics 100% map and align to PANCE blueprint topics. We have a total of 100 cases coming to our library by June of this year. So about 70 more cases are going to be added to the library by June. And as you can see over to the right-hand side here, all the topics are going to fall under the umbrella of the required Skippy rotations for PA students. One other factor I wanted to mention, as we know, professionalism has become an increasingly important task category in the PANCE blueprint, and we know it's a vital competency within the curriculum. In response to this, a professionalism section is planned for future development in DDX, and this section will include case scenarios designed to assess and reinforce key aspects of professionalism, such as, think ethical decision-making, empathy, effective communication, and collaboration with patients and healthcare teams. So at this time, I'll turn it over to Kevin. Kevin, anything that comes to mind when thinking about areas within your curriculum that will allow for imminent integration of DDX now that the pilots are completed?
I think what we'd love to do, we're still kind of working through, we're a state-run university and budgets are always have to be part of the conversation, but we really see a lot of potential value here. And so where we're at now is talking through the potential applications of something like DDX for clinical year students, for didactic year students. And a few that kind of came up even this morning in talking about it was, I mentioned we kind of teach our curriculum in a modular format. So, with 2 weeks of neurology, to actually have maybe a case that's associated with this, and whether that would be part of the assessment, actually, you could see applications there, but or even just practice, right? To be like, okay, you've been learning this book learning, let's try to apply it to some cases here, certainly in preparation for the clinical year. Standardized patients is another thing that our students really would love more of. They would do so many of them if we could, but obviously the logistics and the cost of having a person coming in and being an SP is substantial. We have about 70 students total between our 2 years. And so just the time involved, the cost, that sort of thing, something like this can provide a simulation and really useful feedback where they're getting kind of similar exposure. They can do it on their own time potentially, or learn more asynchronously. So there's an awful lot. And then, things like professionalism or, cultural humility, ethical decision making, even IPE type activities. I mean, I just think there's a lot of really cool potential applications that they're considering and things that we could really put to use as a way to kind of, again, speaking to accreditation standards, to be like, this is specifically what we do to address this and that. And then you'd actually have data that you could say, look, this is what we found, et cetera, and be able to, triangulate and do all the stuff that you have to do for the accreditation. This might be a nice way to get at that. So that's kind of some of the discussions we're currently having.
Awesome. Thanks for your feedback on this. At this time, Kevin and I would love to open it up to any questions. If you liked what you saw here and like to learn more, or even set up a trial to be able to play around with the cases at your own time, please feel free to use this QR code to set up a meeting with me, or send me an email, whatever is easiest for you. So we'll stay on here for a few more minutes if there's any questions that come through.
Alyssa, I have the first question from the QA feature. That one says, it's from an anonymous attendee. It says, Kevin, congratulations on your accreditation submission. I'm curious, what was the most surprising thing you discovered while using DDX during this pilot?
I think for me that I had kind of trialed the cases, right? Like I had gone through them on my own, so I kind of had a sense of how they worked, etc. What it was really fun, but honestly, I really kind of expected to get a lot of grumbling from students about like, yeah, you wanted to show up early and run through this thing, and yeah, whatever, it's a thing we could use, and they loved it. Like they kept like people have come up to me afterwards, they've been emailing me about it, like just they felt like I think it was really useful, and they too could say like, wow, I think that would have really helped my development at various stages, and they thought it was just super cool that the program was considering it. So, and I don't think it was just the bagels I brought in. They weren't that amazing. So it was really fun to see just their reaction to it. They had a lot of fun with it, and it was cool to see them trying to apply their skills to these things and trying to get the stars and that sort of thing. It is kind of got a little like, video game aspect to it where and being competitive and type A people, like they were all over trying to outperform one another. So that was probably the biggest thing, that just how much they really enjoyed it. Obviously, if, when it's assigned work or whatnot, maybe it'll land a little differently, but they bought in. They thought this was great and that the program should certainly pursue it, was their feedback.
Next question that I have here, also from anonymous attendee, says, you mentioned practice. Do you feel this tool would help their muscle memory?
I can take that one, Alyssa, too, if you want. I think
Sure.
restricted to either one of us, but I think that's the biggest thing, right? Is that students really need that practice, right? They need to think of themselves as the provider in the situation, not knowing these details and needing to solicit them, to get some feedback on that. I mean, I think just to get used to the fact that on rotations, they're going to be asked and, kind of pushed a little bit, right? They're going to be pushed to say like not only what the answer is, but why do you think that, right? And to be able to really justify their answers and understand that there's gray areas in medicine. And I thought that the tool gave them a good chance to kind of practice some of those skills. So hopefully, again, when they get in the actual situation, it feels a little less scary for them.
Definitely. And to add to Kevin's response, we can actually take the university's curriculum and map it to the particular cases that we think would be best aligned with their current curriculum. So right now we have 27 cases, but when we have 100 cases, that might be a nice feature as well to make sure that what you're teaching in the curriculum aligns perfectly with these practice cases.
All right, I've got just two more here. I know we're over time, so we'll move quickly. Second to last one, anonymous attendee. Would you see students using these cases multiple times to drill certain scenarios?
I mean, I certainly think you could, right? I think that obviously the scenario it's not going to change a ton in terms of like, um, what the diagnostic tests are or what the differential is, et cetera. I guess where I see a lot of utility primarily is to say like a student might be struggling in a particular area, whether it's diagnostics or whether it's, interpreting tests or whether it's coming up with differential or what have you, to be able to say like, okay, give them a case and they can see how they've done. And then hopefully, maybe a similarly aligned, not identical case, but that gets at some of those same things to say like, okay, yeah, you ran through the chest pain case. Let's have you do it. And these are some things that you found out. We can talk about them, et cetera. And then we're going to give you a belly pain case, or we'll give you another variation of this. And let's see how you do with kind of targeting similar skill sets without the exact same case. There may be some benefit to repeating it, or at least going back through and seeing kind of how they might approach it differently. But I guess personally, and Alyssa, feel free to weigh in, but just thinking like, what are the skills I want them to get at? And are there maybe more than one case where we could really target that so that they're getting something new? They're getting the material, but in a slightly new way. So it really kind of hopefully challenges them to really think about those underlying concepts.
I completely agree. And as they, if the students repeat the case, it's only going to enhance the framework for how they should be speaking with patients, how they should be taking this into real life clinical scenarios. So I feel like you can't practice one case too much. Each time you go through the case, you're going to learn something new, whether it's a new way to approach the patient or a better way to ask a question.
All right, final question here, another anonymous attendee. Since the cases are graded in skill level, are they labeled as such, or do faculty users need to determine this on their own?
Well, I'll let you kind of take that primarily. In my experience at the moment, at least with what I was given, it was one we were kind of figuring it out on our own. But again, that was just for the pilot going through to say like, what cases would you like to do? And I was kind of enjoying going through them to see what DDX was offering and seeing what was there. But I'm sure Alyssa can speak more specifically to that question.
Absolutely. So something we're trying to integrate right now is labeling the cases, whether they're easy, medium, hard, and um, who or at what phase in the PA program those cases might be good for. Another thing we can do on the DDX side is customize the case. So if you're just dealing with didactic students who are in their first or second semester, let's say, we can truncate the case right after the differential diagnosis. So they're not going into the orders and interpretation of the diagnostic tests and the management. So that answer is kind of twofold, but we are working on getting in skill level for the faculty members to be able to identify what cases are best for their students.
All right, that is all of the questions that we had submitted on the Q&A.
Awesome. So I just want to take a moment to thank everyone for joining us, including our fantastic guest speaker, Kevin Wine. And for those who may be watching this recording at a later date, everyone's engagement and feedback have been invaluable. We appreciate your time and participation. And overall, we hope you found this session helpful. And we look forward to continuing the conversation and collaboration in the future. So thank you once again. Have a wonderful rest of your Monday.